Hi, good morning, everybody. I had a busy morning trying to get down here on Amtrak, I'll tell you. I started out at 6:30 this morning. I think I should have just driven down to D.C. Anyway, let me just tell you a little bit about my office. I am the regional administrator for Region 3 of the Centers for Medicare and Medicaid Services. We comprise 6 states. It's Pennsylvania, D.C., Delaware, Maryland, Virginia, and West Virginia. So it's pretty much the mid-Atlantic states of the country that my office oversees or manages. This is a picture of Dr. Don Berwick, for those of you who don't know Dr. Berwick. He is the current administrator for the Centers for Medicare and Medicaid Services. And he was formerly the president and CEO of the Institute for Healthcare Improvement, or IHI. It's an organization that is leading the effort to improve healthcare throughout the entire world. And Dr. Berwick co-founded IHI, and he has spent his entire career really investigating and exploring opportunities for quality improvement in healthcare. We were familiar with Dr. Berwick before he even came to CMS, and we were delighted when he decided to take the job as administrator. He has brought his experience to CMS to help the agency accelerate improvements in the healthcare system that aim to improve the lives of patients, the health of communities, and to lower healthcare costs. Program integrity, or fighting fraud, is integral to the 3-part aim in which CMS is focused these days. We recognize that there is a need to improve our ability to fight fraud, to help keep a lid on rising healthcare costs, and to keep patients, our most vulnerable citizens, protected against healthcare fraud. So today what I'm going to do is I'm going to share some information about how CMS is fighting fraud, waste, and abuse. What I'm going to review just at a very high level is the CMS structure and our approach to program integrity. I'm going to talk a little bit about the contractors and the partners that CMS works with to fight fraud. And then I'm going to give you a series of links to various resources, some of which were just noted in the materials that you showed us. But resources that will help you navigate questions or issues after this conference is over. So by the end of today's presentation, what I'm hoping is that you have, one, a better understanding of what CMS is doing to fight fraud in the Medicare and Medicaid programs. I hope you're going to know how CMS works with a variety of contractors, and I'm going to tell you, there are a lot of contractors involved in helping CMS fight fraud, waste, and abuse. So I hope you'll understand what the function and role of some of these contractors is. And then you'll also know where to go to get more information and have a set of resources available to you. So let me start at the beginning. Let me just see. The Medicare and Medicaid programs, for those of you who have never had a history on them, they began in 1965. And Medicare is for people who are 65 years of age or older, people who are disabled or who have end-stage renal disease. Medicaid is for people with limited income and resources who are aged, blind, and disabled. And Medicare is funded through FICA taxes or through payroll taxes. You know, everyone who works in this country is required to pay about 2.9% of their annual wages, salaries, and compensation in Medicare taxes. Medicaid, on the other hand, is a federal state program that is primarily administered by the states. So in essence, we have 50 different state Medicaid programs in the country. And it's financed mostly by federal dollars. CMS also helps to fund the State Children's Health Insurance Program, or CHIP. And just recently, we took on certain programs related to the health reform law, and we will be doing a lot more with regard to consumer information and insurance oversight regarding the pre-existing condition insurance plan, which we're messaging about these days. We'll be getting involved with the health insurance exchanges that this country will stand up in 2014. So we've really just taken on a whole another set of, of work. Over $800 billion is spent each year on the Medicare, Medicaid, and CHIP programs. And if you think about it, only Social Security and national defense cost the taxpayer more. CMS programs equate to about 19% of the total federal budget. That's huge. That's just astounding when you think about it. And currently, there are over 100 million beneficiaries. So CMS covers, in essence, 1 in 4 lives with health insurance in our country today. Now, I'm sure you know the costs for these programs, they're in the news almost every single day of the week. Costs are projected to grow at approximately 5.4% every year for the next decade and hit about $1 trillion in the early 2020s. So, why are these programs so expensive? Well, there are a lot of reasons as to why they're expensive. For one, we have the baby boomer population, which we're anticipating coming into the program over the next, many years. They're retiring. Life expectancy is increasing. So more and more benefits are drawn down from these programs for longer periods of time. As medical care becomes more sophisticated, costs increase. The reimbursement system, and CMS can take credit for this. It's such that doctors and hospitals make more money the more often they see patients, prescribe expensive drugs, and perform elective procedures. They know this, and they know that Medicare will pick up the tab for this. And on top of all of this, outright fraud and abuse cost CMS program billions of dollars each year. We're finding that the more we look into finding fraud, the more fraud we find. So our return on investment is very good. We're realizing more and more that criminals are very organized, they're very sophisticated in their approach. So it's a very, very difficult problem to try to solve. So let me try to talk a little bit about what we are doing to try to fight fraud. I think I'm missing a slide. Well, let me talk a little bit about, I'm sorry. CMS is making a strategic shift in our fraud fighting efforts. We're trying to go from a pay and chase mode to a prevent and detect mode of operation. And just last year, we put a firm emphasis on fighting fraud by creating the Center for Program Integrity, which brought together all of the program staff at CMS that work to combat fraud and abuse. In the past, you had people in the agency working on Medicare fraud, you had others working on Medicaid fraud. They were decentralized throughout the whole organization. So as part of the Affordable Care Act, we created the Center for Program Integrity and centralized all of the staff who work on fraud and abuse activities so that they could work in a more coordinated fashion and leverage the skills, the talents, and the information that they have. So our program integrity activities are now coordinated across Medicare and Medicaid, and we're trying to target certain incentives to specific problem areas. We're also implementing a lot of the new authorities that ACA afforded us, giving us additional front-end protections against improperly paid claims. We're developing innovative new approaches to payment oversight, such as using predictive analytics, which is something that I'm sure you're familiar with, that a lot of credit card companies use to try to identify aberrancies. We're strengthening partnerships with the private sector, and we're trying to increase transparency in our operations. Just keep in mind that our top priority at CMS is to try to preserve and protect access to quality, safe, and affordable care to Medicare, Medicaid, and children's health insurance beneficiaries. So these are, this is our focus. These are the reasons that we work toward trying to combat fraud and abuse in these programs. And hopefully what we're doing will help us to achieve this. Now, I'm just like, okay, there's a slide here. Well, there's a slide, possibly you have it in your packet. It's a map of the U.S., and it shows you the organization of CMS. There are 10 regional offices organized into 4 consortia, each of which handles a major business line. So you have 4 consortia, one dealing with Medicare Parts A and B, one dealing with Medicare Parts C and D. You have a business line or a consortia focused on Medicaid and CHIP, and then the 4th business line is focuses on quality and survey and certification. And each business line monitors suspicious activity and any interactions with beneficiaries, providers, and contractors. We also have 3 sub-offices focused on anti-fraud work, and they are located in Miami, Los Angeles, and New York. So there should be a slide, as I said, that just displays the regional boundaries for CMS. Now, the Medicare business. Let me just go over a little bit on this. Medicare is, as you can imagine, it's the largest health insurer in the country. Harry Truman was our first enrollee in the Medicare program back in 1965. He was actually 81 years old when he joined the Medicare program. And when the program began, it officially began in 1966, we covered 19 million people in this country. 19 million. Today, we cover 47 million, and that number is continuing to grow. Each working day, Medicare pays over 4.4 million claims. Each day, we pay over 4.4 million claims to 1.5 million providers with a worth of about $1.1 billion every working day. Each month, we receive almost 19,000 provider enrollment applications to the Medicare program. I mean, just think about those numbers. They are really mind-boggling when you think about it. In 2010, the total outlay for the Medicare program was $524 billion. So this program, Medicare alone, it's just huge. For Medicaid, we pay over 2.5 billion claims a year for more than 54 million beneficiaries in 56 states and territories. Now in 2014, with health insurance reform, the number of eligibles for the Medicaid program is going to grow substantially. People who earn less than 133% of the poverty level, so that's about $29,000 a year for a family of 4, they will now be eligible to enroll in Medicaid. And currently in our programs, there are 8.8 million Medicaid beneficiaries who are titled or termed dual eligibles. And these are people who qualify for both the Medicare program and the Medicaid program. They are the most chronically ill and costly individuals when we actually look at the data around this subset of our population. And in fact, these enrollees account for approximately $300 billion in federal and state spending. So we see the dual eligible population as an opportunity for savings in our program by trying to improve care, coordinate care for this subset, by trying to simplify and align Medicare and Medicaid rules. So as part of the Affordable Care Act, we also have created a coordinated health care office to try to align the Medicare and Medicaid programs to better analyze data associated with the dual eligibles and to try to conduct demonstrations, new models of care delivery for this population. Okay. So I mentioned earlier that we created just last year the Center for Program Integrity. And all of the anti-fraud staff in CMS are working now for one director, Peter Bedetti. Not sure if you've ever heard Peter speak, but he is now the director of CPI. Their focus is really to consolidate Medicare and Medicaid program integrity efforts, to integrate functions and achieve efficiencies. Again, we want to move away from that pay and chase mentality toward a focus of prepayment prevention efforts. And we're trying to focus our intervention on specific problem areas by targeting integrity efforts to certain geographic areas of the country and benefit categories. And we're trying to work very closely with federal agencies as well as with the private sector, because especially the private sector shares some of the same kinds of issues that we share, maybe not related specifically to health reform, but the type of fraud and abuse that occurs in the private sector we find is similar to Medicare and Medicaid and what we're experiencing. Now, the primary goal, of course, is to pay claims correctly by preventing fraud through effective enrollment and education of providers and beneficiaries. We want to try to detect problems early through medical review and data analysis. We want to coordinate closely with contractors, partners, and law enforcement agencies, and of course enforce rules and regulations fairly and firmly. There are a range of activities that are directed at the various causes of improper payments. And when I go out and talk to providers and when we hear from providers at CMS, we find that they're very concerned that CMS or the OIG or law enforcement is going to come down really hard if they miscode a claim. And one message that we try to get across to providers, we try to reassure them that we realize that many providers just make an honest mistake. However, we do recognize that there is a small minority of providers and others who commit healthcare fraud and abuse, and that costs the Medicare program billions of dollars. So on one hand, you're trying to reassure providers that we're reasonable, but on the other hand, you are trying to raise their awareness that fraud exists to the tune of billions that cost the taxpayer money each year. The law states that a person committing fraud acted with intent. So there is a big difference between an honest mistake and outright fraud. And if someone commits or submits an erroneous claim, we really try to work with that person to correct the problem and recover the erroneous payment. But if we become aware of waste in the system, we really try to seek out inefficiencies, whether it's our inefficiencies at CMS or those at the provider, but we really try to seek out what led to those inefficiencies. And then, of course, purposeful intent to bend the rules is abuse, and while that may not be a criminal activity, we try to use what's available to us in the form of civil monetary penalties to try to correct the situation. However, when we find fraud or when we suspect what we think appears to be fraud, that's when we bring law enforcement into it to investigate the situation or pursue the situation in court. Most fraud results from a false statement or a deliberate misinterpretation where diagnoses are just reported incorrectly. Procedures are put in place to try to maximize payment, and these are all deliberate acts with intent to defraud the government. Or billing for services that are not furnished are other examples. And as you well know, there are a whole host of examples of fraudulent activity, and this is what we're keen on and trying to identify in the activities that we've put into place, our monitoring activities. So let me talk a little bit about the contractors and the partners that we work with, because we certainly don't work alone. We use several specialized contractors whose primary focus is on program integrity. These contractors use different types of technology and methods to fight fraud. So, MACs were mentioned. These are the Medicare Administrative Contractors. And they are really the central point in CMS's National Fee-for-Service program. These contractors are what we used to call the fiscal intermediaries and carriers, and they process all of the Medicare Part A and B claims. So that's what they focus on, A and B claims, fee-for-service Medicare. They conduct prepayment audits of claims, and they work closely with functional contractors to ensure program integrity. So let me take you through some of the functional contractors that we have working with us. One contractor type are the ZPICs, or the Zone Program Integrity Contractors. And they work between the MACs and law enforcement to take potential issues and referrals of suspicious activities from the MAC. They screen cases to determine if they should be referred to law enforcement. They conduct data analysis, medical review, and develop high-quality fraud cases for law enforcement. So that's what the ZPICs are focused on. You have CMS field offices. I mentioned the field offices in Los Angeles and Miami, as well as the 10 regional offices. They work with law enforcement to study issues and coordinate leads and ask other law enforcement agencies to investigate leads. We rely on external partners such as states and others to identify possible causes of fraud, to serve as kind of our eyes and ears on the ground if fraud is suspected. And the OIG, we try to work very closely with the OIG in investigating cases. And then, as you can imagine, as the largest health insurer in this country, we receive a tremendous amount of data every single day, which is analyzed in different ways to identify trends or suspicious activities. And we conduct claims review on both pre- and post-payment and try to make a special effort focusing on either high-risk providers, services, or services that there are a high volume of services or they're high-cost services. Now, we also have the RACs, the Recovery Audit Contractors, which is a very popular topic with all types of providers these days. And the RACs, their primary purpose is to identify past improper payments that were not detected through existing program integrity efforts. If a provider bills fee-for-service Medicare, then you can bet his or her claims will eventually be subject to review by the RACs. They identify overpayments, but they also identify underpayments through either automated reviews or complex medical reviews. They can focus on certain provider types, and they do focus on certain provider types, but most really concentrate their efforts on high expenditure and high rates of growth in claims for certain services. And then the RACs, what they do is if they suspect fraud based on their review, they will refer that case to the ZPIC to then further develop, who will then work, the ZPIC then works with the MAC or works with law enforcement to then further investigate the situation. We have QICs, or Qualified Independent Contractors. Basically, they handle the second level of appeal for providers. So the MACs do initial determinations on claims and redeterminations, and then the QICs do the second level of appeal on claim denials. There's the National Supplier Clearinghouse. They focus specifically on the DME POS suppliers, durable medical equipment, prosthetic, orthotic, and supplies. And they're responsible for issuing and recommending revocations of billing privileges in the Medicare program for medical equipment suppliers, so that we're making sure that Medicare beneficiaries are using suppliers or going to suppliers in the Medicare program that meet our standards. Then you have the Coordination of Benefits Contractors, and they assure that Medicare is secondary as a payer. So if someone has workers' compensation, or if they're working aged, or if they're in an auto accident, then Medicare would be a secondary payer, and we utilize a COB contractor to make sure that coordination occurs. So all of these entities work at different levels of the program for the purpose of assuring that we're paying claims accurately and that we're protecting the Medicare Trust Fund. So this next slide provides a framework for all of the AB contractors in the Medicare fee-for-service administrative functional environment. These entities share information and data with the MAC, which serves essentially as the hub for processing all claims. And as you can see, the functional contractors really play an essential role for CMS in combating fraud and abuse. Now this map gives you the MAC jurisdictions. Some of the jurisdictions do not have designation because there's a protest pending, or there has been a corrective action that's been put in place because it's a competitive environment. You'll see that for J12, which is the Highmark Medicare Services, that covers pretty much the Mid-Atlantic area. This is a map showing the DME MACs, and for Jurisdiction A, that is the National Heritage Insurance Corporation, NHIC, that is the DMAC for the Northeast. We've got the Home Health MAC, and Cigna is the contractor there for the Mid-Atlantic states. Here's a map of the ZPIC contractors, and for most of the Mid-Atlantic and North, the ZPAC contract is still being procured, so we don't have that contractor in place quite yet. For the RAC jurisdictions, that gives you a map of those jurisdictions. DCS is the MAC for the Mid-Atlantic. Well, you can see Connolly Consulting covers Virginia and the South. So we've covered program integrity in just Part A and B of Medicare. So that gives you a perspective for Parts A and B of Medicare. But now I'd like to just touch on Part C, which that covers the managed care plans in Medicare, or Medicare Advantage, as you might be familiar with, and also Part D, which is the Medicare Prescription Drug Program. So for Part C and Part D of Medicare, we utilize the Medicare Drug Integrity Contractors, or MEDICs, to handle benefit integrity issues in Part C and D of Medicare. And we have one contractor that covers the entire country. The MEDIC is responsible for receiving and cataloging and filing all complaints of fraud, waste, and abuse that they receive. They conduct audits, they investigate marketing violations, they review compliance issues at the Medicare Advantage plans or the drug plans. They support law enforcement. They try to educate law enforcement and providers. So the MEDIC really does a whole host of functions related to fighting fraud and abuse in the Part C and D program. I just mentioned really a few. They use investigators that are assigned to certain geographic areas across the whole country, and the investigators are given cases to review, and based on their geographic area, and there are 20 different offices throughout the country. So that takes care of Medicare A, B, C, and D. Now I'm going to move to Medicaid. And we have integrity contractors in the Medicaid program. They are the Medicaid integrity contractors, or MICs. And they review provider claims, they audit providers, they identify overpayments, and they educate providers. These contractors are intended to support the state activities, not to supplant the state activities. And basically, there's 3 types of Medicaid integrity contractors. We've got contractors who audit providers, so Medicaid integrity contractors whose sole purpose is to audit providers. They conduct desk audits to identify overpayments. We have MICs that review and analyze claims, so their focus is really to look at data, to develop algorithms and analyze Medicaid data, and if they suspect some aberrant behavior, then they would turn over their case to the auditing side of the Medicaid integrity contractor. And then the 3rd type of MIC is the education Medicaid integrity contractor. And they basically use the findings that are coming out of the audit contractor and the review contractor to develop educational materials for providers and stakeholders to try to raise awareness around issues and provide training. So this is a list of the Medicaid integrity contractors across the country, and there is a link on that slide, a website that you can go to if you would like more information about the Medicaid integrity program. Now let me just take you through some resources that are available to you. Probably the most important resource is how to contact your regional office. If you go onto the CMSgov website and put in regional offices, that will take you to a contact sheet that will provide you with management contacts for each business line. Another site is the Medicare Learning Network, and this site is aimed at educating providers about the Medicare program. There are some great webinars and tools and resources, publications for providers on the Medicare Learning Network. We also have resources here, one geared toward consumers, which is Medicare.gov. Another one toward professionals, CMS.gov. I mentioned the Medicare Learning Network. You should be familiar with StopMedicareFraud.gov. That was in your packet. And then there's one link there for the MAC contacts for providers. And you can go to that site for contact numbers by state. And then these website links will get you into all the functional contractors that I talked about this morning. And then here are a few more as well. So that pretty much covers my presentation today. I hope it's a lot to try to understand, keep track of. There are a lot of players in this whole thing. I think when you get an appreciation for the scope and the size of the Medicare program, you can really appreciate that, as I said, CMS can't do this alone.